So we will get started. Conflict of interest, I have nothing to disclose. So the objectives of this presentation will be malnutrition in children in the ICU setting. And what I'm going to do is present our Sick Kids Critical Care Nutrition Guidelines. And there's different sections of that. There's enteral nutrition, feeding intolerance, parenteral nutrition, and lastly, I will briefly discuss chylothorax management here at Sick Kids. There are several organs that require close monitoring and management in the postoperative child, such as the heart, the lungs, and the kidneys. And in the acute or the immediate period, we may not always be thinking of the GI tract in terms of can we feed or when can we feed this baby or child. So I'll be touching upon feeding initiation in the upcoming slides, but this first slide is just to introduce, keeping in mind the gastrointestinal system and enteral feeding. So here we have a little girl that was transferred to our intensive care unit years ago, and she had to have a re-repair of her cardiac defect. And as you can see from this picture, she is extremely malnourished, which is malnutrition defined as the imbalance between nutrient requirements and intake that results in cumulative deficits of energy, protein, and micronutrients that can negatively affect growth and development. So the goal of nutrition management in the ICU setting is to either prevent hospital-induced malnutrition or if the child is already malnourished, to prevent further decline. And as you can see here, she has thinning hair, bony protrusions, muscle wasting, and subcutaneous fat loss. And that is all from poor nutrition delivery from the transferring hospital. They tried their best, but they weren't able to get her nutrition into her through IV or enterally enough to maintain her growth and body mass. So underfeeding in the critical illness, whether it's adult or pediatrics, and even in a cardiac unit, what we see and what you saw from that picture is a loss of fat and muscle, which then can result in increased time on the ventilator, immunosuppression, which results in increased nosocomial infections, and poor nutrition also results in impaired wound healing, which can increase length of stay. So ultimately, mild, moderate, and or severe malnutrition increases morbidity and mortality and prolongs ICU and hospital length of stay. And it also increases cost of hospitalization. And for children who are then discharged from the hospital, there can be a very slow return to their previous level of activity if they leave in a malnourished state. So as clinicians, how do we manage the undernourished child or prevent the child from being undernourished? And this is where we developed feeding guidelines for our center. And before I present some of the components of these guidelines, in the upcoming slides, I would like to point out that these guidelines were produced for a mixed PICU and CICU patient population. Although our units are managed separately by specialized team of experts, we share the same location. So for our purposes, we deemed it necessary to create these guidelines for a mixed unit. So these are evidence-based guidelines that were constructed by a team of dietitians, physicians, nurses, and allied healthcare team members. They were created to assist with standardizing practice with an overarching goal to improve the timeliness of feeding initiation and delivery of optimal nutrition. And as you can see, they're divided into 4 parts. So there's enteral nutrition, assessing readiness to start feeds at admission, and Q6 hourly. There's feeding intolerance, parenteral nutrition, and monitoring. So we know from the literature that nutrition algorithms and guidelines have aided in the achievement of improved nutrition delivery in critically ill children. With this in mind, our guidelines were developed with the following goals for enteral nutrition: assessing EN readiness at admission and Q6H, clarifying contraindications to enteral nutrition, and the indications for initiating parenteral nutrition. Also, encouraging adjuvant therapy to promote EN tolerance and clarifying when to interrupt enteral nutrition. So assess and react. And this leads me to when to feed and when not to feed. As you can see here, enteral nutrition readiness should be assessed at admission and then Q6 hours after that. The child's abdomen should be soft, bowel sounds should be present, and we have defined hemodynamically stable as a lactate less than 5 millimoles per liter and not increasing, with good perfusion on exam. So this leads me to when not to feed. So contraindications to feeding would be if the child is hemodynamically unstable. So that's increased in inotropes or vasopressors, and this is determined by the physicians. Or if there's a GI bleed or obstruction, and also in keeping with our NPO guidelines, if there's an expected extubation or an intubation. So this is a picture of our feeding guidelines. And as you can see, we have both methods of bolus and continuous. And then we have a gradual progression to an acute illness goal, which we have defined as 80% of maintenance fluid. And this does not include IV medication infusions. And in determining whether we are going to feed bolus or through a continuous method, we initially assess aspiration risk. So does the child have a depressed cough or gag, history of severe reflux, impaired neurological status, or severe bronchospasms? And in these situations, we would consider post-pyloric feeds if there's concern for aspiration risk. With respect to our more fragile, vulnerable population of the single ventricle kiddies, we have a slower feeding progression for this group as they are susceptible to NEC due to their cardiac function. So we do a more judicious kind of feeding plan with them. And this brings me to feeding interruptions. So this is a good figure that came out of a paper from Nilesh Mehta from Boston Children's Hospital, and that was published in the journal Parenteral and Enteral Nutrition. And as you can see, there's from the light blue color, there's avoidable interruptions, and the dark group blue color, unavoidable interruptions in feeding. And as you can see for tolerance, 48% was avoidable. And so that helps us in determining how to come up with guidelines that can strategize how we can ensure feeds are being given and how to avoid that. The less optimal kind of feeds that aren't given. The other area you can see here is extubation, intubation was 81% avoidable. Feeding tube issues avoidable, and you can see the different procedures there. So when developing our guidelines, we determined that we can consider holding feeds only at the time of all ICU-based procedures for intubated patients. So that would be bronchoscopies, chest physiotherapy, CVL insertions, lumbar puncture, if the child's in a proning position, or transports. Um, Feeding interruptions for children in the intensive care unit have been well described in the literature. In an attempt to minimize these interruptions, we have created this list of procedures when feeds are to be held just at that time versus for hours ahead of a procedure. However, we do follow our institutional MPO guidelines for intubation, extubation, and all anesthesia-based procedures. Um, and moving on to my next slide, there are feeding interruptions, which sometimes they could be 2 hours, they could be 4 hours, they got 5 hours, and we wanted to make sure that our guidelines would be able to guide our nursing staff, our fellows, and residents to know how to restart a feed. So if the patient is stable, so if the patient went to cath lab, came back, and they're stable, we would restart our feeds at the previously tolerated rate. If the patient was unstable and gets to the point of being able to feed because they're safe, then we would restart at a previously tolerated rate. So feeding intolerance. So this algorithm provides detail on assessing and reacting to feeding intolerance. Monitoring tolerance to feeds every 6 hours. And at the top of the algorithm, there is information describing mild to moderate or severe symptoms. So for example, if a child has a moderate symptom of 2 to 4 MSS per shift, feeds are to be continued at the current rate, and the nurses will hold the feeds and notify the team. Also, you will find details about information on several signs of feeding intolerance, such as constipation, diarrhea, emesis, and necrotizing enterocolitis. So with respect to parenteral nutrition, we have developed these guidelines, indications for parenteral nutrition. So if the child is unable to provide a minimum of 50% of calories of their caloric goal for premature neonates by day 2, term neonates by day 3, infants by day 5, and children and adolescents by day 7 of admission. These are parenteral nutrition, or these guidelines were launched in 2018, and this was after a landmark study was done, which some of you may know. It's called the PEPINEC study, and basically, this is a very large population study that looked at providing parenteral nutrition on admission or waiting 7 days later. And what they found is in the late group, there was a reduction in infections, length of stay, and days on mechanical ventilation. We have, at our center, we have never I can't say never, but we don't usually start children on PN on day 1 of admission to the ICU. We assess whether or not they're getting enteral nutrition, and then we promote enteral nutrition delivery as much as possible. And only based on our guidelines would we start parenteral nutrition. There was a subgroup analysis from the PEPINEC study that was published the same time we had launched our guidelines. And in this study, they looked at neonates, and again looked at them in terms of starting on admission or starting PN 7 days later. And so they did find that there were fewer nosocomial infections. However, the risk for the development of hypoglycemia episodes had consequences. And what they found is, and I've put it here, however, I can't really see. I can't really read it, see it, but anyways, basically they said until there are larger studies are done looking at late parenteral nutrition in this group, they didn't confidently recommend that this be followed due to these hypoglycemic episodes that occurred in the study patients. However, we do know that parenteral nutrition is required, especially for kids infants who are diagnosed with necrotizing enterocolitis. So feeding practices in critically ill cardiac infants is strongly influenced by fears of the infant developing NEC, a condition that is characterized by intestinal inflammation, disruption of mucosal integrity, epithelial necrosis, and bacterial translocation. NEC in term infants with CHD has not been associated with EN, but is believed to be a consequence of intestinal hypoperfusion and splanchnic ischemia. Although studies have not shown an association between enteral nutrition and NEC in neonates with CHD, there is significant variability of feeding practices across institutions, particularly in the postoperative period. So at our institution, we generally have general surgery consults for our patients, and to determine the extent of the diagnosis of NEC using Bell's criteria. And so our infants may be NPO from 5 to, it could be as long as up to 14 days. And important nutritional considerations of this is that when we start feeds, we do a slow escalation of feeds once it's reintroduced. And the dietitians, myself and my colleague Anna, we would assess daily parenteral nutrition, evaluating that and during feeding escalation to ensure optimal nutrient delivery. Despite limited evidence to guide standardized feeding practices for infants with CHD that have NEC, the use of human milk and donor milk is always encouraged due to its favorable impact on the intestinal microbiome, the promotion of gastric motility, and the reduction of intestinal inflammation. And then the last section of my presentation today will just touch upon chylothorax. So this is a trauma to the thoracic duct that generally happens during surgery, and it has leakage of chyle into the thoracic cavity. And chyle is a fluid that is high in fat, high in protein, and high in lymphocytes. So this is important from a nutrition perspective. And we want to reduce this lymphatic drainage as much as possible. And it is in the early, it occurs in the early period and post-op. So at Sick Kids, we follow a chylothorax SCAMP, or a standardized care assessment management plans. And as you can see there from the top, lymphocyte fraction greater than 80%, or chylomicrons present. And then you have the decision tree of what is to be done next. And it is a larger document. This is only one section of the document, but it does give information on when to use octreotide, or if the child would require further medical management. From a nutritional perspective, we here at Sick Kids, we start the children on an MCT, or a minimal fat diet, with specially designed formulas that have a high MCT content and a low long chain content, to avoid the long chains that need to be metabolized through the lymphatic system. And we have to ensure that these products also have sufficient essential fatty acids, because this is imperative for infants' brain growth and development. The diet, the formula diet, is continued for 6 weeks post chest tube or JP removal. And during this time, we do encourage mothers that they continue to pump their breast milk, because this will be reintroduced later on. We also have, for children with cow's milk protein allergy, we cannot use these specially designed formulas. So we have alternative formulas that can be used, which is Vivanex Pediatric, and it has a high percentage of MCT oil in it, but it is not comparable to Portogen or Monogen. So we actually alter and adjust the recipe to make the MCT content a bit higher. The other formula that we sometimes have used in the past is called Tolerex, and that has a minimal LCT content and a high carbohydrate content. But we have to be very careful with this formula to ensure that it has essential fatty acids in the amounts that are required for infants. So the use of modified human fat has been used in many, many centers, and we currently do not use it. However, we have a dietitian that is going to be implementing this in the hospital, and she's working with the food service department on really the logistics of how to set this up and spin milk. So just a bit historically, in an earlier study by one of my colleagues about 10 years ago, she investigated the use of modified fat breast milk to resolve chylous pleural fusions. But what she had found between the skimmed breast milk and the formula is that the children did not grow as well on the skimmed breast milk that was fortified, but they didn't see growth in terms of weight for age or length for age Z scores. And this was a non-randomized open label study. So after her study, we do think it is very important to use mom's breast milk, and that was our goal. It's just a matter of how do we change the fortification of the breast milk to ensure growth. So that's where my other colleague came in, Sarah DeLoro, and she did a study. What she did is a nutrient enrichment with a higher protein level that was added to the breast milk. And in her concluding in her study that was actually just published earlier this year, she did find that the fortification resulted in supporting growth and the resolution of chylothorax. And so this was the impetus to really start the process of putting this in place in our hospital. It just takes, some time for this to be done. So Anna will probably be speaking more on this in her presentation, but it's equally important in an intensive care unit setting is anthropometric measurements. So in the cardiac critical care unit, we came up with certain times when infants and children can be weighed. So for infants, we have 3 times per week, Sunday, Tuesday, and Thursday, with lengths and head circumference done on a Sunday. Sundays were seem to be a less busy day, according to our nursing colleagues, and then older children to be weighed once a week. The other, if a child's in our unit for a longer time or premature infants, we do ask for daily weights in certain situations for some kids. And then the other measure that we're starting to do a bit more often is doing a mid-arm circumference. This is difficult because the child has to be pretty much at a dry weight and not too fluid overloaded, because then we're not going to get accurate measurements. And also we have to have a free arm access for that child. So in summary, the goals of nutrition care in the cardiac intensive care unit is early and routine nutrition assessments of all children admitted to the unit, early initiation of enteral nutrition when child is deemed safe to feed, the use of guidelines to promote initiation, advancement, and monitoring of nutrient delivery, and guidelines that prevent strategies to reduce intolerance and minimize feeding interruptions. And this is key to good nutrition delivery that results in growth and to decrease malnutrition and the consequences of that. And we also have guidelines that recommend the timing of parenteral nutrition, as I had explained earlier. And routine monitoring of anthropometric measurements are really important in our children. And that concludes my presentation at this time. So I'm going to set Anna up with her presentation, and then the two of us will welcome any questions that you may have for us.
So it looks like it's, oh yeah, okay.
Yeah, I did it again. I have a problem.
That's okay.
Thank you, Joanne.
Am I right now?
No.
Okay.
No.
Okay.
Well,
Okay. I just want. Yes. Yeah. I will. And then I'm going to take this.
Hi. Hello.
Hello.
Okay.
Are you listening?
Carlos, are you okay? Okay.
Hi.
Hi.
I want to ask if are some concern about how to nutrition a newborn with taking prostaglandin with heart disease depending on the duct arterioles. Most of all, hypoplastic left heart syndrome, for example.
Joanne, are you still there? I think she might not have heard the question. Anna,
Okay.
just hold
Yeah,
on.
1 second. Sorry, we had the microphone down. One moment. I'll let Joanne take it back for the question. One moment.
You might
Okay,
have to
sorry, we
repeat it.
didn't hear it. I think, yeah,
Yeah.
they'll definitely have to repeat it. Sorry, yes.
Sorry. That's okay. Sorry about that. Yes, I'm sorry, I missed the question.
Hi, congratulations. How is your goal? How do you nutrition newborn with taking prostaglandin, for example, with hypoplastic left heart syndrome?
So how do we feed our newborns with HLHS before they have surgery?
Yes, or TGA while he's taking prostaglandin.
Yes, we will feed, but we won't feed full feeds. So we'll provide like a minimal volume of feed, and we'll start very gradually and slowly. And sometimes those kids will require parenteral nutrition as a supplement.
Okay. Okay, we
Because
try We tried Intrio first with a small volume.
Sorry, you try.
Intrio by tube, nasogastric tube first.
Oh, you. But yeah, NG tube first, right?
Yes.
Because the literature on the feeding with prostaglandins, it's really hasn't really directed us in terms of whether it's yes or no. It's a bit conflicting. So that's why we feed, like some feeds, it might be say 50% of their goal, and then have to use PN to supplement. But it all really just kind of depends on the child and when they're having surgery as well.
Okay, thank you.
Oh, I hope I answered your question. Thank you.
Oops, I think this is very sensitive. Yeah.
I really appreciate your approach to cyclothorax.
I know. Okay. Hi everyone. Just give me one moment just to set up. Okay, if everyone can see me. I'm Anna Tedesco-Bruce, as Joanne mentioned, I'm one of her colleagues, also who's worked quite some time in the cardiology population here at Sick Kids. My pleasure to be here today and speak to everyone. So I will start the presentation, and just a reminder, Joanne will be joining us at the end for questions. So if there's more questions coming, we definitely welcome those. Okay, one moment, please. Okay, are you seeing my screen right now?
Yes, we can see it.
You can. Okay. Do I need to do anything, Joanne? That's it. This isn't going to fall. Okay.
Maybe angle the camera towards your face a little bit. We can't see.
Okay.
There you go.
Is that better?
Yeah.
Okay. Sorry.
Perfect.
Cecilia's asked me to angle it better to see me. Okay, great. All right. Thank you. So, okay, just to start off, I definitely have nothing to disclose at this time. And you know, Joanne had did a great summary of a lot of a variety of topics that we are challenged with in this patient population, and I just wanted to start out reviewing a few introduction points with you. The general overview I'll highlight shortly, but I just wanted to start off and possibly reinforce some of what Joanne has said, but just to identify that children with congenital heart disease are prone to nutritional challenges and undernutrition. And for children with unrepaired congenital heart disease, growth is often compromised due to caloric imbalance, which stems from high energy expenditure, and then poor nutritional intake as a result of feeding intolerance, fluid restriction that we're challenged with, and impaired absorption. And I'll chat about those points going into my talk. The resulting undernutrition is associated with frequent infections, poor wound healing, and increased mortality, creating strong incentives for early and aggressive nutrition intervention in this patient group. Management strategies are therefore aimed at ensuring that dietary provisions meet the child's distinctive needs. So that's important to keep that in mind, that we still do have an individual assessment approach. And by prioritizing human milk for infants, increasing energy delivery through higher caloric density feeds, which I'll chat a little bit about, and the use of enteral feeding tubes, parenteral nutrition for energy supplementation, and then medical therapy to treat feeding intolerance when it presents itself. So as you can see, the perioperative period also presents with very unique challenges and opportunities for nutritional support, including early introduction of enteral nutrition to support and improve post-operative recovery, and ensure that feeding delivery meets the child's energy and protein requirements to avoid a catabolic state. So generally speaking, I've tried to incorporate different aspects that I thought would be of interest to all of you, but as we mentioned, we welcome questions at the end. I'll just very briefly identify the overview. So I will be going into the nutrition challenges that we are presented with in this patient population, consequences of inadequate nutrition. We'll talk a little bit about growth, and then I'll dive into breast milk for this population group because it is our gold standard for all babies, but this particular group is it's very beneficial if we have the availability of it, and I'll touch upon some infant formulas from our practice point of view at our institution. So our patient population here, obviously we follow all congenital heart disease patients that are diagnosed prenatally, but we also potentially have patients that are transferred from referring hospitals. So depending on the age of the patient, so we can become involved from birth all the way through into childhood. And again, from when we're talking about the cardiac unit, we're looking at potentially preoperative, postoperative patients, pardon me, as well as just a piece which I'm really not focusing on for this talk, but I welcome questions at the end. We also continue to follow them post-discharge. We have a nutrition clinic that's linked with all the cardiologists. So we continue to support nutrition through the whole spectrum. So again, not something I'm focusing on for this talk, but happy to, and welcome any questions if anyone does have some at the end. And as you can see, you know, cardiomyopathy, ECMO, transplant, we do tend to become involved with all of them as nutrition is quite vital. So when we think of our nutrition challenges, our patient population does vary even amongst different diagnoses and what the plan of care is. So throughout the perioperative period, it's quite crucial that we appreciate all the differences that are demanded of that patient and work towards achieving the best we can with our nutrition care plan. So when we're looking at how best to obtain a history, if it is not a newborn and it's an older, could be a couple of days old infant, still very important to obtain the key pieces as to whether feeds were started, if they were, what were the feeds, and if they were not, we need to appreciate that as well. So we collect that data through the families, the care providers that are involved at the time, our community providers, including referring hospitals, and if applicable, other multidisciplinary offices, whether it's a physician or, you know, there's a lot of different kind of care providers that have the options of care providers in the community. So we want to ensure we collect all that information. And then of course, from the medical chart, you know, any previous consults or pertinent data as well. And then something to really keep in mind is when we collect that nutrition, the nutrition history, is there's a lot of pieces to that we value in our assessment. So we don't want to make any assumptions when we're trying to assess what's best for that patient. They're still to us very unique, and I think that's one part of our practice that I really want to enforce, that it's not one size fits all. Yes, we have literature out there, but at the same time, we definitely want to take the time and approach that patient as an individual and see what's gone on with them specifically. So in the feeding history, that's a big part of understanding, was there intolerance with feeds, and or was there better tolerance with some feeds? Was there breast milk? Was there not? Were supplements incorporated in there? And if so, we need to understand and appreciate what supplements, what dosage. And then definitely I'm going to get into the growth parameters and looking at how we screen and how we work on those into our plan. So when we're looking at, pardon me, when we're looking at challenges of providing nutrition support, I've broken it down a little bit just for the sake of identifying some clarity within each aspect of it. But overall, when we look, there's one aspect that looks at decreased nutrient intake, and with that, there's many reasons from a cardiac standpoint that add the element of challenge to this, and as what that tends to be extremely common is tachypnea with feeds. You know, they work harder, their expenditure is higher, but that decreased nutrient intake in this case is really reflective of their challenge with the suck, swallow, breathe response. As they're working harder, it's difficult for them to feed and maintain their nutrition on their own orally. That leads also to early satiety when patients do feed, whether it's at the breast or whether it's when a patient, pardon me, with congenital heart disease feeds, whether it's at the breast or on the bottle, we need to assess efficiency of that feed, and seeing sometimes they just they tucker out, and they may also take too much air in depending on the nipple. It could be at the breast, it could be also with the bottle. So that early satiety also leads to poor intake. Any swallowing challenges, we at our institution have the benefit of having occupational therapists that we work extremely closely with and value their expertise. So if we did have any concerns, whether or not it was with respect to feeding efficiency or any risk of feeding, we would definitely, get there and have their involvement, and they would direct the plan from there. And then the other challenges we have for congenital heart disease patients is fluid restriction. And this is something that is quite very, very common across the spectrum of patients, across the spectrum of diagnoses, and something that we manage on a daily basis. And there's a variety of ways to do that. And I'll get into that a little bit in a little bit as well. And then quite common is feeding intolerance, unfortunately, for this patient population group. When we talk about fortified feeds, or depending on their clinical status, how stable they are, we definitely see as their clinical condition is compromised, the feeding goes with that. And so we have to, it's a fine balance of ensuring that we do our best to optimize our nutrition provision. And then one of the challenges in hospitals especially is feeding interruptions. And this is really important. And sometimes it gets missed, more so because we're so focused on looking at all the pieces in terms of how the baby's tolerating, what's the baby doing. We look at the order, but we don't really sit and calculate, okay, they had an interruption for MRI, or they had extubation, and so on. So those feeding interruptions add up very quickly. And if we look at one day, and the next day potentially they did not extubate, and then the next day they want to trial extubation again, over a couple of days, you can imagine how we compromise our delivery. But as dietitians, that's something that we definitely focus on and monitor daily. And when we are concerned, there's ways around that of trying to optimize and ensure they receive better nutrition. And then on the flip side, we can also look at increased nutrient intake as well, being one of our challenges. So Joanne did talk about malabsorption, poor gut perfusion. She discussed neck as well, and chylothorax. So those obviously are other challenges that that we need to help manage to provide adequate nutrition to this patient population group. And the increased energy requirements I touched upon is their cardiorespiratory status. So when they're trying to feed orally, potentially their rest rates are, here in our institution, generally speaking, if they're above 60, we tend not to want to use a bottle to feed, or to orally feed, pardon me. So they will possibly need supplemental NG tube feeds. And just as I mentioned as well, something from an inpatient unit, thinking if it's a patient that we're going to manage long-term, trying to get them home, we also want it ideally to have them on bolus feeds with the NG tube, because we do practice a lot a follow-up in our clinic with NG tubes at home, bolus feeding, but something to keep in mind. So when we're developing that nutrition plan, even though they're on the cardiac unit and they may still be with us indefinitely, when we start talking about potentially them going home and needing to grow for potentially surgery, or potentially avoiding surgery, really important that we work towards that plan that's achievable at home. And that's part of what we assess here within this realm. And then within that, we need to think of what the catch-up requirements are, because a lot of times our patients are challenged with growth and they fall behind. So we do tend to aim above the age-appropriate requirements to support weight gain. So just talking about the gastrointestinal tract a little bit, and the GI system, what I wanted to highlight here really is looking at we talk about, Joanne talked a little bit about kind of our intolerances, but when you think of gut perfusion and all the challenges that our patients have, it does impact their GI transit time. There is delayed gastric emptying. It does impair the motility and ultimately impacts upon feeding tolerance and that nutrition supporting growth. In addition to that, a lot of our patients do experience at some point in time during their clinical management ascites and large liver. And as you can see in this diagram, this is just an example of a patient who had tachypnea, abdominal distension. The liver is quite enlarged. All of this impacts nutrition provision and challenges us at a whole new level of what can we do to ensure this patient will be able to sustain and maintain that that nutrition intake. In addition, we have the small bowel and we have mucosal edema, which also impacts on nutrient absorption and compromises that. And then inadequate nutrient delivery as well may result in atrophy as the cardiac muscle cells are also compromised in nutrient delivery in these patients. So generally, I think Joanne touched upon more from a GI perspective and the villi as well, but brush border mucosal atrophy can also lead to severe diarrhea and steatorrhea. So this is something that we monitor, obviously, and I'll get into a little bit about feeds and what we can do to sometimes help that. But it is something that we need to be very aware of and have on our radar. And then lastly, you know, looking at decreased bile acid pool also can affect the end result, which can lead to fat malabsorption in this population group. So ultimately, cardiac patients are at risk for further caloric and fat loss if protein energy malnutrition continues, right, and persists, but so require ongoing assessment and as Joanne mentioned, at times potentially even supportive parenteral nutrition for the interim. So looking at consequences of poor nutritional status, I think, you know, most of us are familiar that from a neurological standpoint, 3/4 of the brain does develop in the first 2 years of life. So it is crucial that we ensure the best nutrition from all aspects when we're looking at macronutrients, you know, protein, fat. It is very important to balance what we're providing in terms of nutrition for this patient population. And then that obviously leads into impacting their developmental maturation. So that can also inhibit brain growth. There's research out there even at birth, noticing when the brain has, if they're suboptimal in terms of identifying at birth and growth with the brain, it can actually be linked with some other anomalies. I know there's a lot of research going on with that and as well in our center. So those are all aspects that we do want to be as aggressive and proactive early on to ensure we're giving them the best progression through their care phase. Social can be very challenging as well. And this is just to touch upon very briefly because we have the outpatient component and we hear a lot of this from families when they come back to clinic and they're managing their child at home, usually when it's with either an NG tube, potentially a G tube. And there's a lot of comparisons out there from a cardiac patient to a non-cardiac. And sometimes they have other children and families still compare to their child that's a non-cardiac patient. And there's a lot of stress involved for families because sometimes, you know, socializing with other families, you know, parents have said, you know, my friend says what's wrong with my child, they're not as big as their child, and you know, and it's trying to help and support them, explaining that cardiac patients do grow differently. They grow within what we expect, which has helped a lot of families. I've gotten the feedback a lot of times that they feel comfortable hearing that it's our norm for our patient population group that their child's not demonstrating anything that we're not accustomed to seeing or expecting to seeing. And just hearing that at times has really helped them at home in terms of their coping abilities. But that's something that we can't underestimate, because once we get the families out, they, you know, although we set up community supports as best we can, it's there's a whole other element that we're not aware of unless families confide with us. So something to keep in mind. And then obviously, as we all know, the economical longer hospital stays, fiscally, obviously, that's a challenge as well. So when we're looking at GERD or gastroesophageal reflux disease, it is particularly common, as I mentioned, in this patient population group. And some symptoms of this, are abdominal distension or tenderness, arching, retching with feeds, recurrent emesis following feeds that can result in a decrease of voluntary feeding volume, or potentially withholding of feeds from the care provider as well. So we really want to respect the cues of the infant, the child. That's a really important aspect to ensuring when we are hopefully at a place where they can feed better orally, we support a good experience, a positive experience for that infant or child. And hopefully in respecting those cues, we make it less stressful for family as well, which, you know, we always want to avoid leading to force feeding. But this is one aspect that can't be underestimated as well. And we always want to keep it at the back of our minds when we're supporting families, whether it's in hospital, whether it's even in the CCU, if we're trying to put them on the breast and it's not going well, just to respect the patient's signs and cues. And then when we're looking at management, you know, when we talk about poor enteral delivery, it can also arise from feeding intolerance secondary to GERD, as I mentioned, but there's also gastritis, delayed gastric emptying, and poor motility, or malabsorption, which is secondary to poor gut perfusion, gut ischemia. So the way we try and manage, again, not with a one size fits all, but potentially smaller, more frequent feeds, depending if they're bolus feeds. We can look at post-pyloric tubes, depending on what the enteral tube is that's supporting their nutrition. Within that, there's therapeutic formulas, so formulas that are more broken down, easier to digest. You know, we have an array of those, and I'll just touch upon them at the end of my presentation. And then keeping in mind with NG tube, with tube feeding support, that we have to think, is this patient going to stay in hospital, or is this patient potentially going home? We, at our institution, don't practice sending a patient home on an NG feed that's continuous, or any post-pyloric and an NJ feed. We do not support that practice at risk, at concern for safety and aspiration. So, you know, within your own institution, you just want to ensure that you're prepping that family accordingly. And then obviously any medications, PPIs, prokinetics, et cetera, to support and hopefully manage the reflux. So leading into growth assessment, when we're looking at this very vital piece of information that sometimes does get underestimated as to how much it can actually tell us of how that patient is progressing. There's not just one aspect to it, and a lot of us focus on the weight and the weight change, and there's a lot to be said for that, absolutely. But when we're looking at growth, we actually need to have the other parameters, so the length of the baby or the height depending on the age, and the head circumference, which is crucial in not only telling us overall growth and how in terms of our provision of nutrition, but also brain development can really highlight any other potential concerns for that baby, and possibly other undiagnosed concerns. And part of when we're tracking these parameters, the importance is to appreciate that when different people measure, that can also impact on what that data would look like on a growth chart. So in saying that, the weight, we obviously, from a cardiac perspective, have to consider that it's not true only true weight gain with nutrition, but we know it's affected by fluid. We have to think what has happened with the diuretic that day, what has happened with the diuretic that week, what has happened with nutrition delivery. I mentioned earlier about interrupting feeds. So that's something concerning as well. So as a practitioner, if I already have assessed that baby on a daily basis and can appreciate that they have had a lot of feeding interruptions, but their weight has increased, and depending on what's happened with the diuretic, regardless, I know the likelihood is not that it's related to nutrition, but rather fluid shifts. And as a team with our other care providers, we need to have the discussion to see, okay, what's going on with this child? How can we better manage nutrition and also manage potentially fluid balance with the aspect of managing diuretic treatment. Head circumference, as Joanne mentioned, is a weekly practice here. Weights, we have 3 times a week. Sometimes on the inpatient unit, we actually go to daily weights. They're a little more stable, depending again how closely we're monitoring fluid changes. But it has worked well. And one thing just from our center, as Joanne mentioned, we practice the same. So whether they're on the cardiac unit or in the ICU, having nursing have those standard days for measurement has really helped, because our patients tend to obviously continue across the continuum. So we want to be sure the practice is supported, and that's something that we've endeavored over the last couple of years, but it has proven to work well for nursing, for our nursing colleagues. So that's really important when considering putting a practice in place, how we can support it and what works for everyone involved. I just want to highlight the assessment and these serial measurements, how important they are to give us an idea of growth, or to give us the whole pattern of growth. One-time measurements are really only reflective of as a screening tool for that child, but then if we're looking at following them along the spectrum, serial measurements are what we need to provide the best care. And just quickly to highlight the proper way of measuring, obviously across the crown, we see on the left of the head circumference, and then the length is really important. And this tends to be sometimes when it is challenging to get a length, we definitely don't want to use a measuring tape. That really can skew the growth on the growth chart. Really important to use the length board. And as you can see here, ideally, if you have a second person, and we're always happy to help each other in clinic if the parent's there on the inpatient unit or in the ICU, as colleagues, we help each other, holding the baby's head as best you can, and then having that flex in the foot where it lines up as close as best you can, ideally as the picture is showing, and then taking that measurement, and that is the most accurate way of measuring length. Looking at growth failure in this patient population, so most neonates with congenital heart disease are born term with anthropometrics within the normal range. So it's, again, if we're talking about prematurity or SGA, et cetera, those are not included in this. And then children with CHD are challenged with impaired growth by noticing over time, measuring slower increases in any of the 3. Usually it's all 3, but there are times when potentially the head is lagging behind. So those are all concerns from a nutrition standpoint that we need to address our nutrition plan and identify the macronutrients and delivery of those macronutrients accordingly. And then you can tell in this patient population group, and if any of you have been actively following, you can really, really quickly see a decline in their growth failure, pardon me, and the risk of malnutrition, depending on what is presenting with this patient, what challenges we're presented with. So it does place them at high risk, and we need to definitely have a very active approach and trying to support their needs. And then if you look actually at the literature, it is still, despite our recognition of this group, acute malnutrition still continues to vary from about 33% to up towards 50% as well. So when we're looking at actually the data and reviewing, so I've tried to combine, you know, the WHO recommendations and our practice as well for this patient population group. We want to at times try to provide enough nutrition to support normal growth. But the challenge in this population is that not only do we need normal growth, but we also need catch-up weight gain. So that can be challenging at times. But generally speaking, if we're looking at normal growth and you look at the recommendations, anywhere from it could be upward towards 35 or plus grams, depending on where we're at in this 0 to 4 month range. But on average, 30 to 20 grams per day is the average weight velocity that we're striving for, and then catch up would be on top of that. And then in clinical practice, when we're looking at calories per kilo, you know, we're looking at basically age appropriate, and generally speaking, if you look at, depending on where we're at with from a diagnosis point of view, it could be up towards 20 to 30% additional caloric needs for this patient group to support growth. I just want to highlight again how important it is to monitor and that daily weight change. If you can, you know, have daily weights. If you can't, as Joey mentioned, we aim for 3 times a week, depending if they're on the ICU or cardiac unit, and then continuing to monitor the length in the head to determine the growth pattern. So looking at our practice here as dietitians, and we support a lot of our practitioners in the community as well. One thing that obviously I mentioned is challenging is obtaining fluid for feeds for growth, right? And historically, just in practice here, we tended to be a little bit even more restrictive with TFI, total fluid intake. And that became challenging because we would have to fortify the feeds to a much higher concentration to try and provide adequate nutrition. I would say in practice over at least the last 10 years, we've noticed a change in that we have a balance of providing the diuretic and adjusting the diuretic to be able to ensure we achieve good nutrition. So we're not putting them at further risk as best we can manage. So the first thing when you're looking at trying to provide adequate nutrition, you want to aim for the maximum volume dictated by their medical condition. We want to then consider advancing concentration cautiously once that fluid intake is reached. And cautiously does vary depending on the patient population, the diagnosis, pardon me, within that patient group. Obviously, our single ventricles, as Joanne mentioned, we would not fortify early on in life. And when we do choose to potentially need to fortify, we do it at a very much more cautious approach than we would a baby who with a VSD, say. So when we're actually fortifying or concentrating, depending what we have available for the feed, we want to always achieve our goal protein. But then there is, depending again on the formula we're using, some formulas, depending on if it's an infant formula compared to say Portagen. Portagen has a higher protein content, so we do have to monitor that. And so we fortify or concentrate accordingly to ensure we don't give too much protein. So once we do that, and we still need to go above and beyond for caloric delivery, we consider adding modules. So that would be a carbohydrate source or a fat source. And as Joanne mentioned, in say, for example, it's our kiddos who are babies with chylothorax, we would consider MCT oil potentially, or we could consider a carbohydrate source. And one of the products we use here is Polycal. So that's just a quick summary of the steps involved, but within that, there's a lot more involved in us assessing macro and micronutrient delivery, assessing tolerance within this, and unfortunately, most times the first approach doesn't always work, and there's feeding intolerance depending on how much fortification we have had to provide in this feed, or how high the concentration can be. So that's part of our adjustment of the feeding regime. So I just want to really, in summary, at this point, highlight that dietitians do monitor and reassess, ensuring we're supporting the growth pattern we would like to achieve in this patient. And within that, that balance of nutrient provision is key when we're prescribing nutrition support, and we're reassessing that on a regular basis. So I'm going to move on to another section of my talk, which is something that we take great pride in trying to do, as best we can as a center in supporting, and worldwide, I know it's definitely been recognized as the gold standard, and that's mother's own breast milk. So when we're looking at the benefits of mom's breast milk, I'm going to try and divide it into a few practical aspects, but I wanted to highlight a few pieces here, in that we know it's a gold standard. It is comparable to infant formula, always tries to mimic breast milk, and it's 0.68 calories per mil or 20 calories per ounce, depending on your center. We do want to ensure we support, as per Canadian Pediatric Society and World Health Organization, exclusively breastfeeding, and for the first 6 months of life. And again, in our patient population group, it's challenging sometimes to maintain breastfeeding at all, but the provision of breast milk. And then we do want to ensure we also supplement with vitamin D accordingly for this patient population group. So mother's own breast milk is always the first choice, whether it's at the breast, whether it's expressing, and we definitely want to ensure that that they receive colostrum, and support practice, so that we're patient in letting mom's breast milk come in, and that can translate into some stresses when there's an expectation of how much volume the mom's supposed to have. We need to appreciate that this is not a mom who's gone home with a healthy baby trying to breastfeed or trying to produce breast milk. This is a mom who is now and in a stressful state, so it can be challenging. So we want to provide any support possible. And then another part of this that I want to just highlight is that all breast milk does contain valuable immune and growth factors and nutrients. And colostrum does contain significantly more immune factors. And that milk that mom produces in the first few days after birth is crucial. And we really want to try and support as best we can to provide that to the baby. Hand expression can also be effective at removing this colostrum of the first few days after birth, if they're at a place or somewhere that they don't have the option of having a breast pump, but hand expression has been shown to be successful as well. And as health professionals, we all play a key role in supporting, trying to encourage moms to provide their own breast milk, especially for our cardiac patient population group, as they're so vulnerable. So in terms of pumping, I'm not going to get into detail, but really regular pumping is key. Here in our center, in our institution, we have our great colleagues, lactation support, and they will become involved for this patient population group. It's challenging as well for them from a resource point of view, but it's very, very helpful. And they will get involved right at birth to talk to mom about pumping potentially, or to support potentially wanting to put them on the breast, a combination of effort. And as I mentioned earlier, that breast milk can be fortified to optimize energy and nutrient provision. I'll explain a little bit more about that shortly. One thing that's really important to appreciate is what is normal milk production, and it does vary in practice depending on who's had experience. Depending on this is a learning institution, so depending on where practitioners are coming from, some may think 30 mils Q3 day 1, day 2, and that's not realistic. So all I really want to highlight here is appreciating that it could be anywhere from a few drops from day 0 to 48 hours, all the way to a few tablespoons. But remember, what I highlighted is that this is colostrum, and it's so nutrient dense in terms of providing what's needed for the immune system of that baby, that we want to ideally wait for that that breast milk and have it be the first feed to introduce to the baby. There's a lot of literature as well that's supporting the gut microbiome and how it really sets the the premise for life of their immunity when they receive that breast milk as the first feed, and ideally at least the first few feeds, again, to get that colostrum, and not introducing formula, which I'll get into shortly as well, what options we have. And then days 2 to 4 are really when we see the breast milk volume. We should see the breast milk volume just start to increase gradually. It varies for every mom. And again, just always reminding ourselves, this is a mom who is not at home. She's in a stressful state. So production, will not be the same, obviously, but appreciating that and providing good encouragement to them, because it can be frustrating for moms as well when they're not producing very much. And that's really what they wanted to provide for their baby. So we want to encourage regular stimulation and regular emptying to help increase production. So this leads me actually into the donor milk bank, and I just want to chat a little bit about this. There's milk banks all across the world, and here at Sick Kids we have the Roger Hickson Milk Bank across the street at Mount Sinai, which was established in 2013. And the benefits of when we look at donor milk is obviously keeping in mind that it does have all the benefits to prevent infections and inflammation. And so when we think about it, it's protecting against serious life-threatening infections. So we want to encourage, if they do qualify for a donor milk program, as a second option to mom's own breast milk. Joanne did talk about NEC, so there is strong literature even in the PREM population that it does protect against necrotizing enterocolitis, and it's easily digestible. And just to keep in mind, it's short term, it's not a long-term solution, but it's a temporary transition in helping mom, ideally encouraging mom to be pumping, so we can combine in using breast milk when we have it and donor milk when we don't have enough breast milk. But eventually we need to transition off. And if there is no breast milk, we do at some point have to transition over to formula. Just to highlight, the donor milk from a perspective of questioning, the safety of it. It is pasteurized donor human milk, and it's pooled from many moms. It's not one mom that donates the milk, and that's a question we do receive often. So for families to understand, and religious reasons sometimes don't allow for patients to consent to donor milk use, and that's understandable. But we always present the option to all families and let them make that decision. But it does contain the immunological properties and antifungal properties that I mentioned earlier, and we really do encourage it in our patient population group, just knowing that, depending on the diagnosis, that they are at higher risk of NEC, and infection rates are higher. So using donor milk sometimes can also help delay the use of PN, depending on what's going on with the patient complexity. So as I mentioned, I just thought I'd show you that there are criteria at our center. They have expanded the criteria depending on the donor milk bank supply, but it definitely requires consent from the parent or guardian. And we've recently expanded the birth weight. At one point it was less than 1,800 grams, and now it's expanded most recently to less than 2,000 grams, again, based on supply. And then for us, I just want to highlight, it's any patient that we expect to go to have surgery within the first 4 weeks of life, or any post-necrotizing enterocolitis patients, they will qualify as well. We have made exceptions in our single ventricle population group who are at high risk, who fall outside the 4 weeks, but this is something as an exception, on an exception basis, and we discuss it as part of the multidisciplinary team, and just to keep track of I guess ensuring there is good supply of this donor milk, but right now we're in a good situation, so we're able to make that exception. And sometimes we've, just a couple of our patients that come to mind that have been here for quite some time. One patient in particular, almost a year, we did keep them on donor milk for months because they had recurrent NEC as well. So even outside the recovery of NEC, we tended to continue the practice. So Another aspect of using mom's breast milk, which is a great practice to support, is something called oral immune therapy. And I know there are centers that are using this, but this is again, keeping in mind that human breast milk contains many factors that protect babies from infections or infection-related illness. And skin to skin does produce protective antibodies that actually transfer into breast milk, and these provide protection against harmful bacteria. So even if we're not able to do that skin to skin, we want to encourage using the practice of oral immune therapy. And what this is essentially taking mom's breast milk to provide mouth care for her baby. And we do need fresh breast milk, and I'll explain what fresh means, but to practice this, this therapy. And it is standard of care for babies who also are unable to feed by mouth. So when we look at the benefits for using oral immune therapy, so basically first of all, it is easy and effective intervention to practice with these patients. As I mentioned, it does boost immune system and it does also provide local and systemic protection. Patients, babies do tend to begin feeding and reach full feed sooner. And research has also shown that they experience enhanced growth in having OIT. And it also provides a really positive oral and sensory stimulation for babies. So that's when we're looking at the benefits for baby, but it doesn't end there. We also have benefits for parents. We definitely have increased bonding. Again, keeping in mind, you can imagine these parents have a lot taken away from them in terms of what they can do for their baby, depending how critically ill they are. But having them learn how to practice OIT is something we support here as an institution, and they are able to we provide them an opportunity to be involved in their infant's care, whether it's one parent, two parent, both parents. They have given us feedback that that's something that they look forward to throughout the day to be able to do with their baby. And it does actually, research has also shown that there is increased rates of breastfeeding and milk supply supported by doing this at the bedside. And then I just want to also mention, I guess, just in terms of looking at the mechanism behind applying OIT, combining breast milk with baby saliva actually creates an environment that reduces harmful germs and boosts healthy bacteria in the baby's mouth. And this good bacteria essentially creates a healthy oral environment, and then that travels to the gut to support its healthy development and protection and maturation. And then, as I mentioned, research, there is quite a bit of research supporting this practice and protecting the baby from developing both infections and harmful inflammation. There are inclusion criteria and exclusion, not limited to this, but at our institution. So generally speaking, we include all tube-fed patients, or if patients are MPO, and gestational age greater than or equal to 23 weeks. And exclusions are dependent on the patient at the bedside, and if they're showing signs of stress when we are practicing the OIT, any gagging, retching, just overall concerns from the nurse or the parent at the bedside, or if our occupational therapist has identified oral aversion, then we would know that and not practice it. But that's from my experience been very rare. I won't get into too much detail with the oral immune therapy and how to practice, but a couple of aspects of it that I just want to highlight is that really when you have the applicator, you want to be sure it's an applicator that doesn't absorb too much of the breast milk, because the baby could be at risk of choking or aspiration. But basically you want to just coat gently. It's like painting the mouth. So you just want to take it inside and coat both sides of the mouth and the lips, and then you discard that swab. You want to obviously observe the baby for their acceptance and comfort in practicing that. And then generally speaking, we can do it as often as every 4 hours as part of routine mouth care, but really important that we would do it after oral suctioning. And depending on, you know, nurses have also become kind of given us some feedback if the baby's on bolus feeds every 3 hours, potentially practicing it every 6 hours is very okay as well. It's just trying to apply it where we can is definitely beneficial. Sorry. And then one other piece to this, what I wanted to mention is when we're talking about obtaining fresh breast milk, what that means. So ideally, if we're practicing and the mom is at the bedside, we can obtain anywhere from 1 to 2 mils after each pump, if possible. Again, it depends on her supply. But if sometimes moms obviously can't be at the bedside all the time and have to leave the hospital, if they know they're only going to be gone for about 24 hours, we would ask that they would pump off 5 mils, or we keep 5 mils of that breast milk to support its use for 24 hours. And we also, if they are planning on being away for more than 48 hours or up to 48 hours, if they have 10 mils, we can also do that, and we keep it in the fridge and it's good up to 48 hours. And when we remove it from the fridge, we just want to put it, stir it around, put it on the applicator, and put it in a sterile kind of container near the baby just to warm up a little bit before we would apply it to the baby's mouth, just for acceptance. So I'm just going to briefly just highlight formulas and indications for use, but I know all institutions vary depending on what we have as products in our center. But here we have Enfamil as our formulary, on our formulary, and it's a cow's milk based formula that we would choose in the case where we don't have breast milk, if donor milk is not an option or consent, and or if we need it to supplement with additional calories, or the supply of breast milk is low. Depending on tolerance, we would look at falling along to more partially hydrolyzed formulas or more broken down formulas. Nestle Good Start is one of those formulas that we would look at. There's also formulas that are lactose free, depending on what the indications are that we may need to consider them. And then we tend not to practice encouraging soy-based formulas, but they are still available out there. So that's something else that we would see in the marketplace. For our cardiac patients, as I mentioned, with struggling with reflux and trying to manage feeding intolerance, we tend to use formulas that are more therapeutic. And what that means is looking at ones that are just more broken down essentially. And one that we have here in our hospital is Nutramigen A+. Another one on the market is Progestamil A+, but these are also formulas that you could use for infants that are confirmed cow's milk protein allergy, or if there's any concerns with malabsorption. You know, even in the short term, sometimes depending on where they're at from a clinical standpoint, these are common practice as well here. And then, you know, I would say our single ventricle population tend to be, especially once they are on kind of more advanced in their progression of their complexity, we likely end up on a free amino acid based formula. And pure amino is one that we use quite often in this population group, and they tend to end up there, unfortunately. So that's something from a practice perspective that that we see a lot, and we just maintain them. If they've tolerated, we maintain them on this longer term. We don't try and challenge them back as long as we ensure they're growing. But there's other indications for using this type of formula as well, above and beyond what our patient population group is needing. I won't talk too long on this because Joanne did mention chylothorax, but just appreciating that there are formulas that are higher in medium chain triglycerides, and Portogen is the one that we use here. She mentioned Vivanex Pediatric, although the percentage of MCT is lower. And there's Monogen, which is in the US, but we unfortunately, we don't have coverage here for Monogen yet, but Portogen is when patients discharge. So it's still our first line of therapy, assuming they don't have a milk protein allergy, but keeping in mind that we need to ensure they can afford to purchase the formula, and if not, how can we support them at time of discharge? Because generally speaking, it's a 6-week treatment phase post GP chest tube removal. Again, depending on where your institution is, we just always want to keep in mind with any formula, is family going to be able to afford it? And if not, how can we help support them using it at home? And just very briefly here, I won't get into all the formulas, but just to appreciate, there's a lot of formulas out on the market for greater than a year as well. And here in our center, we tend to use a couple of the ones that I've just put the pictures of. So Nutrien Junior as a standard feed, 1 cal per mil. And then if they're more fluid restricted, we have more energy dense formulas. And then as you go into different clinical states, depending on if you need something more disease specific, there's a huge variety that you can choose. I just want to end in conclusion. So despite the importance of nutrition support for this vulnerable population, practice is guided predominantly by retrospective cohort studies, as well as designed prospective trials. They tend to be still limited. When we look at perioperative nutrition, I hope we've really provided good support in appreciating the management that's involved, and really how important it is to focus on early initiation and optimizing enteral feeding where best possible. And then just highlighting as well that continual assessment phase is so important to provide adequate nutrition and limit or minimize the risk for malnutrition. And it's necessary also to determine suitable therapies that will aid in their nutrition plan. And then just really looking at research, it's ongoing, and there's a realm of research to review and also to support in future practices to really help improve clinical outcomes for this patient population. So we're privileged to work with them, and it's a wonderful group. And clearly, Joanne and I have been doing it for a long time, but we do enjoy the challenges that are presented in the families we work with, and we're hoping that we shared that with you all today. And thank you again for your time. Okay, now we can welcome questions.
Actually, just in the interest of time,
Yeah.
maybe what we can do is ask people to email the
Yeah,
questions.
absolutely. Sorry, I didn't realize I went over time.
Okay.
Sorry about that.
That's okay.
Yeah, absolutely.
But you have put a phenomenal amount of work into that
Yeah.
presentation, and it really showed. So thank you so much.
Oh, it's our pleasure. And yes, so Joanne, I think, has provided our contact on her, but if not through you, yeah, absolutely.
Okay. Thank you.
Okay, thank
So
you.
if you can, yes, if you can stop sharing your screen.
Yes, I will do that. Okay, all right, thank you. Bye-bye.
Bye.
Bye.
And then our next speaker is Dr. Seth Gray, and he's going to talk to us about endocarditis or pericarditis. We will definitely bring him back if we don't get through it all. He has another meeting, so we'll just start with probably endocarditis.
Yeah, we'll see what we can get through. You can hear me, everything? Is that good?
Perfect.
Perfect. All right. So hi, everyone.